Okay, so let's talk a bit about a couple of other disorders, and then we're done this module. I know it's on the long side, but the questions at the end of ATI I've tried to help you out with. Not that I'm a fan of all of them, but I've tried to help you work through them. So we'll talk about obstructive sleep apnea here, epistaxis, fractures of the nose, pulmonary hypertension. Okay, so let's move on to the next slide. Okay, so obstructive sleep apnea is uh, basically what it says. So while someone is sleeping, the muscles of the tongue and the back of the throat become very relaxed, which is normal, but then they occlude the airway and they frequently have snoring. So snoring is not the issue. Obstruction of the airway is the issue, and they get apnea, right? Periods where they're not breathing. So that's important because if you have periods of apnea, then you're going to have hypoxia through the night or hypoxemia because there's no air getting to the alveoli for periods of time. And then you're going to have hypoxemia because the blood that's coming into the lungs from the right ventricle aren't being oxygenated. So you're getting deoxygenated blood to your left ventricle and then to the systemic circulation, hypoxemia. And that's a problem, right? Because the body doesn't want to be hypoxemic. So what happens is that triggers the brain to wake up when it detects hypoxemia, and you get very poor sleep because you have periods of sleep apnea, and then the brain wakes you up. Okay, then you fall back asleep, you become hypoxemic, the brain wakes you up. So often patients have very poor sleep because of very interrupted sleep cycles. So what does that cause? Well, decreased daytime memory, decreased concentration, decreased making decisions, falling asleep at the wheel. So a driver or a truck driver could fall asleep at the wheel, right? Because of very, very poor sleep from the sleep apnea. So just imagine you go through your whole night and you have, say, 100 periods of sleep apnea, and your brain has woken you up 100 times because it's detecting hypoxemia. Okay. What are the risk factors? Well, being obese because there's more tissue to potentially occlude the airway. Males have higher chances of developing sleep apnea. Alcohol, because it has sedative qualities, so drinking alcohol at night typically makes people snore and cause sleep apnea. Sedatives, such as benzodiazepines, are a risk factor for having sleep apnea. Okay, so if we see people with sleep apnea that are consuming alcohol, on sedatives, we try to remove those to see if the sleep apnea improves. We also advise them to lose weight, okay, because that can improve sleep apnea. So, so often it's associated with snoring because you can imagine as the airway is occluding, you're starting to snore, right? But really the big thing is the episodes of apnea. So 10 seconds or longer and a minimum of 5 episodes per hour. How do we diagnose that? Sending someone to a sleep lab overnight. And they get monitored for periods of apnea, and they have an O2 sat monitor on to see if they're deoxygenating. They're becoming hypoxemic. Okay? So lots of people have sleep apnea that just haven't been diagnosed yet. And they have daytime sleepiness, memory loss, inability to make decisions. Okay. So what's the main treatment for someone diagnosed with sleep apnea? Well, pressurize the airway during the night. So pressurize it and keep the muscles out of the way from collapsing. And that's with CPAP, continuous positive airway pressure. Positioning, so instead of someone lying on their back where everything's going to collapse to the back, like in the image here, lying on the side. Putting pillows on the side to stop them from turning over. Weight loss to reduce some of the tissue that's going to collapse. Okay. So those are the main treatments, and CPAP I would say is the main treatment for this, along with weight loss and removing sedatives and alcohol. Okay, so what's epistaxis? A nosebleed, right? So what can cause a nosebleed? Well, a lot of air goes through your nose, right? So dry mucous membranes, say in winter climates, where there's a lot of dry air, or say you're receiving oxygen therapy, that can dry out your nose, and it can lead to nosebleeds. Nasal steroids, they can thin the tissue in the nose and lead to recurrent epistaxis. Illicit drugs, so probably referring to cocaine here, which can irritate the nasal mucosa and cause nosebleeds. Trauma, so falling on your nose, falling on your face, can lead to epistaxis. Hypertension is a relatively uncommon cause of nosebleeds. They don't typically cause nosebleeds. You can definitely bleed more if you're very hypertensive. They're not usually a cause of nosebleeds, though. Tumors in the nose, low platelets, so thrombocytopenia, anticoagulants, whether it's aspirin or warfarin. Warfarin can make unbelievable nosebleeds where there's just a trail of blood because it just won't stop bleeding. Okay? So, what do we do for epistaxis? We get people to blow out everything in their nose to start with. It's usually a horrendous mess everywhere. Blow everything out, and then direct pressure on the nostrils, right? So we actually have clothespins, so these special clothespins, so that someone doesn't have to hold pressure for 10 minutes. We have these, they look like clothespins, and they just kind of go around the two nostrils and put pressure on them, okay? Sitting upright with head tilted forward, otherwise all the blood is pouring back in your throat. We can spray neosynephrine into the nose to vasoconstrict the blood vessels and stop them from bleeding. If we can see the bleeding vessel, we'll cauterize it with silver nitrate. Okay, that's only if we can see the bleeding. We have these balloons that we can put into the nose, and then we blow up the balloon, and it pressurizes and squashes all the nasal mucosa because we've inflated the balloon, and that often can stop the bleeding. Okay. Um, Epistaxis can be really serious if you're on anticoagulants, as I mentioned, because they can become anemic and hypovolemic. They can really get into big trouble when on anticoagulants with a serious nosebleed. Okay, so fractures of the nose. The only part of the nose you can actually fracture is the upper part of the nose where there's a bone. The rest of the nose is actually cartilage. You can still deviate the cartilage, and then a lot of people call that a nose fracture. But if you look at the image here, the only part you can really fracture is the upper part of the nose because the rest of it's cartilage. And obviously there's pain if there's been an injury and caused a fracture of the nose, or a deviated septum is what we call the cartilage that's injured or damaged. Nosebleeds, epistaxis, significant swelling and deformity can occur. We can sometimes do x-rays to see if there's a fracture of those bones in the upper part of the nose, but we're not going to see the cartilage. Okay? Now, with severe fractures, sometimes we're concerned about that there's cerebrospinal fluid leaking out, okay? Because not far from the upper nose is the meninges and the brain, right? So you can bleed from an area called the cribriform plate, and it'll bleed clear fluid, right? And we can do a test on that leaking fluid to confirm that it's actually cerebrospinal fluid. Okay. For the most part, it's really just ice, an ice pack to the nose, elevating the head of the bed so if they're bleeding, it's not all pouring back to the back of their throat. Um, we'll often have to pack the nose with gauze packing if it's bleeding a lot. Okay, and often people have to come back and have what's called a rhinoplasty, which is correction of that deviated septum. So most people that have a nose fracture, they don't actually have a nose fracture, they have deviated cartilage. And that can be corrected surgically and just straighten out the cartilage. Okay. Okay, so let's just spend a bit of time talking about pulmonary hypertension. So it's just what it says. In actual fact, it should say pulmonary artery hypertension. So typically what happens is there's a disease in the lungs, such as COPD, which is not only destroying the alveoli, but it's also really impacting those capillary beds around the alveoli. And as more and more of the blood vessels are damaged, then you start to get decreased flow through them, and it causes pulmonary artery hypertension. Well, what's the problem with pulmonary artery hypertension? Well, the problem is that now the poor right ventricle has to pump blood into the pulmonary artery at higher pressures. And after over years, the right ventricle starts to get strained and it starts to fail. And you get right ventricular failure called cor pulmonale. Okay? So what can cause elevated pressures in the capillaries of the lungs? Well, let's just start with a pulmonary embolus, a blood clot into the lungs. That's going to immediately cause pulmonary artery hypertension because the artery is blocked, right? So that's going to put a big strain on the right ventricle. What about heart failure? So heart failure, say your left ventricle is failing and there's backup of fluid into the lungs. Well, there's backup of fluid in all the blood vessels of the lungs. So now the poor right ventricle is pumping against higher pressures in the pulmonary artery because the blood's not flowing well to the left side of the heart. So heart failure can do it. COPD, lung disease. Well, why lung disease? Because the alveoli and the capillaries are being destroyed, and there's fewer and fewer blood vessels to pump the blood through, so you get pulmonary artery hypertension. And idiopathic is they're typically an autoimmune disease where the pulmonary vessels, capillaries, and arteries are being attacked and destroyed, and that causes pulmonary artery hypertension. So the end result of all of these conditions is pulmonary artery hypertension, and then that causes right ventricular failure called cor pulmonale. Okay? So any of these symptoms can occur. So shortness of breath. Okay, well, shortness of breath is a very general symptom, right? So many things, as we've seen in this module, cause shortness of breath. Fatigue, why? There's less blood going to the left side of the heart. So there's less blood being pumped out, so they're tired. Okay. Hemoptysis, well, the blood vessels are being damaged and destroyed. So there's hemoptysis. I wouldn't worry too much about the symptoms of pulmonary artery hypertension. I would understand the concept of why COPD or left ventricular heart failure or why a pulmonary embolus causes pulmonary artery hypertension, which then causes cor pulmonale. Okay, I would say that's the most important part. Okay, so in terms of the treatment, well, the treatment just depends on the condition, right? So if it's COPD, well, we use bronchodilators. We may have to use home oxygen to treat the COPD. If it's idiopathic, where just the blood vessels are being destroyed by an autoimmune disease, well, sometimes there really isn't any good treatment, and we'll use oxygen because they're hypoxic. We'll use vasodilators to try and dilate the remaining blood vessels in the lungs. So it really just depends on what the underlying disease is, okay? So someone with idiopathic pulmonary hypertension, they may need a double lung transplant because the right heart can't get blood to the left side of the heart any longer. And the only treatment after they've gone through these medications is a double lung transplant. So it just depends on what's causing the underlying condition. Okay, so most of the modules are not going to be this long. Okay, these are heavy modules, so I've tried to take my time going through them. I just want you to keep in mind, keep the topics separate. What's asthma? What's COPD? What's a pneumothorax? What's a hemothorax? What's a pleural effusion? Keep them all separate. Okay, these often don't combine together. Okay, so what's a rib fracture? What's a flailed chest? So it doesn't mean that if you have a flailed chest, you always have a pleural effusion or you always have a pneumothorax. So just understand the concept of each one and how it affects the respirations. Okay, that's the important part of this, because sure, the questions on your exams will relate to this, but also just if you have a really good understanding of this going forward, you'll retain some of it for the NCLEX. Okay, and that's what I'm trying to give you here. Just a general understanding of what a pneumothorax is, what a tension pneumothorax is, so you can answer the questions and have a good understanding of the mechanics that are happening with these diseases. Okay, so as soon as you see a question about pneumonia, okay, I know what pneumonia is. It's typically a bacterial or viral infection of the alveoli, causing a reduction in oxygen getting to the bloodstream. Okay, so keep things very straightforward in your mind, and it'll really help you going forward. Okay, so I hope this helps. Most of the modules are not going to be this long.